afternoon, everyone. I'm Sasha Sharp. My pronouns are she, her, hers. And as a true educator, I'm going to start with a land acknowledgement first. IU Indianapolis acknowledges our location on the traditional and ancestral territory of the Miami, Potawatomi, and Shawnee people. We honor the heritage of Native peoples, what they teach us about our stewardship of the earth, and their continuing efforts today to protect the planet. Founded in 1969, IU Indianapolis stands on the historic homelands of Native peoples, and more recently, that of a vibrant Black community, which was also displaced. As the present stewards of this land, we honor them as we live and as we study at IU Indianapolis. Thank you. So again, I am Sacha Sharp. I'm probably unfamiliar to many of you, as you are to me, but I am glad to be welcomed into this community to share a little bit today. I hope that you give me grace with my presentation, but I know that I'm on the right track because a lot of what I said in this presentation was covered today, so I'm gonna skip through some of those things. A little bit of background about me. I am the Vice Chair of Strategic Engagement, which means that I do equity, diversity, and inclusion work in today's world where language is being attacked. And I am also the Director of Medical Education Innovation for the Department of Medicine. And so while I have many colleagues in hematology and oncology, I do not do that work. And I stated that to the folks that invited me here, but I trust their decision making and still being fine with me presenting. So, but in addition to that, I have a colleague, Dr. Laura Nephew, who I reached out to because I was like, I'm doing this presentation and I feel like you're better suited, but she's on service. So she gave me some pointers. What I will try to do is move through the things that we've already covered quickly and try to figure out areas where I can fill in the gaps. So the questions that I asked myself as I was presenting or creating this presentation is, firstly, how pervasive is the problem of racial disparities? I want to be specific that I am a researcher. I'm a qualitative researcher and PhD. My background is in higher education, specifically in medical education. And my research is around the experiences of Black women, particularly. I come from a Black feminist intersectional lens when I do work. And so the context and scope of this presentation is within that lens. And I'm really, I think it's really important to think about your lens or your philosophy or whatever theoretical or conceptual frameworks you use when you're doing your work. And so I just want to share that with you all. So while we talked a lot about rural communities and socioeconomic status, this is coming from a more racialized perspective. I wanted to know, are there solutions? How can medical education be used as to drive any of these solutions? And then why is clinical trial representativeness important to health equity? So in terms of the first question, it's going to go over a little bit of what we already know, what was already shared. I don't think I'm showing anything that is in addition to what you all know, and so I don't want to belabor any points. I will say, though, as I was digging into these resources and learning about guidances that were offered by the FDA and particular rules, a lot of that does not exist anymore on those websites. And so I'm trusting my colleagues, I would trust you that are familiar with these things, but they are no longer in existence on any of these sites. So there's also this idea about rates of reporting. So we talk about how a lot of case reports ask for racialized data, race and ethnicity, but there is still a lag in terms of all races and ethnicities, all 5 categories being reported, and that's kind of disaggregate when we look at some of the studies over time. And so this is a little bit more about that distribution of the 5 minoritized groups in their reporting. Okay, so why is it important? As an educator too, I'm going to offer you some definitions to level set and get everyone on the same page, even though I know as I've sat here and I've taken notes, we're there. But first, there's this ethical imperative to research that we must consider and why having that representativeness in clinical trials is important. And so first, as was stated, humanizing a particular person, having respect for the needs of our patients, allowing them to make their own choices, thinking about folks that have a diminished autonomy. Beneficence is very important. We want to maximize the benefits of any of these trials for all of the communities that we serve. But something that I think is rarely mentioned is justice. And so thinking about the folks that don't often receive benefit to the studies that we do, and maybe don't have access to those opportunities. And so this is imperative in all of the research that we do and the education that we do. In my work as strategic engagement, I work with all pillars of the tripartite mission. And so I'm thinking about how we are being equitable in research, inclusive in research, but also in how we train, and also how we practice. And so justice components are important for that. We are unable to achieve therapeutic goals if we don't think about this representation in clinical trials or clinical research generally. And so without diversity, we lack the ability to generalize to diverse populations. We can't minimize those side effects because we're not thinking about safety for those populations. And we're ultimately not going to reduce any kind of health disparities if we're not doing that work. So, like I said, definitions, I think you all know what generalizability is. I'm a qualitative researcher, though, so I'm not as concerned with generalizability. I do a lot of work that is not generalized to the population, but should inform the work that we do when we are doing generalizability work. And I think a lot of folks don't understand sometimes the relationship between quantitative and qualitative work, where they both can inform one another. And so if you find something that's happening in a larger population or community, how can we do qualitative research to really get at the root of it and why it's going on, or vice versa, right? I found out a thing from a particular participant in my study. How can I generalize that up and see if it's happening in a larger population? So the degree to which you can do those things. Many groups of underrepresented and excluded in clinical research can have distinct presentations and health circumstances that affect how they respond to particular drugs, or even how can affect, I think we talked a little bit about this earlier, how they respond to being included in a particular study. And so I think it was just mentioned about having people that look like them, ask them to be in a part of a trial or can understand that experience and engage them in that way. Folks, representation self-identified by race and ethnicity is important, but interpretation requires clarity of thought. And so not only do we need to make sure that we're allowing folks to consider the ways that they want to be a part of a study, we also have to be intentional about that when we're developing our studies. We have to be able to interpret those things well for a generalizable population. And so this is impactful in the work that we do. And we also have to understand that there is no difference on a biological basis. These are all socially constructed areas. And so when we're thinking about racialized categories, a lot of systems impact how people respond to those different needs or have different needs, and it's not biological. So in terms of transportability, again, the definition is approaches to extend inferences made based on the study, and ultimately this can't be done if you don't have a large population of underrepresented, minoritized, marginalized folks in the study. And so it's essential to be able to extrapolate those things that you learned in a particular study to those populations, and we can't do that when we have less representation. And again, minimizing this side effects. Ultimately, we have a lot of data that talks about minimizing side effects for certain European populations and limited data in terms of underrepresented populations. And so, for example, not discovered until 2013, despite drugs coming out in 1951 due to lack of diversity in clinical trials. This is about the CYP2C9 variants, and thinking about how it impacts other populations in that side effect. And so African American populations had a highest variability in response to warfarin due to the different distributions of genetic variants. And some variant effects responses were more common in individuals from African descent. And so that information was delayed because of the not having the information in the initial trial. And again, there's this lack of access to interventions. And so there's example about PrEP and other things that suggest that folks from underrepresented communities are not having the access that they need because they've not been involved in particular clinical trials. Additionally, there is the cost of this failure. So economic modeling estimates that there are large costs when we think about quantity of life, quality of life, and work life, and life labor forces. And so being able to create these types of opportunities for underrepresented communities is very important, thinking about those elements, particularly by 2050, we will spend around $5 trillion in aggregate on costs related to health disparities. Okay, so that I feel like is a lot of the things that I'm preaching to the choir about. And so are there solutions? My colleague, Lauren Nephew, talked about this in one of her papers, which we all should know, in the recent COVID trials. They were able to, when we were thinking about the vaccine, get a good representation, particularly of Black individuals in their study, about 9.3 for Pfizer and about 10.2 for Moderna. And so it can be done. When we're thinking about how to approach this, we think about relationships between the patient and the provider. And so we think about access. How does the patient have access? How does a provider have access? Thinking about, do they even understand and know clinical trial information? Can they make references to their patients? Do they know if insurances, the type of insurance their patient has, is accessible to particular studies? Can they talk about the opportunities? So thinking about the patient, how aware are they? Do they understand what the clinical trial is supposed to do? And we talked about even transportation to the clinical trial. Mistrust is a big thing. I've done some social research, particularly with Black women in maternal health. And in that study, I had 5 focus groups, and the women say, I don't trust physicians and I don't trust my provider level. I don't trust them at all. I know I'm here because I need to get health care, but I don't have any trust for them. That should be built and earned through this process. And unless they're doing something that conveys that I should trust them, I will continue to have mistrust. And so when we're thinking about these strategies, we need to understand that patients come in leveled with mistrust, and we have to work to try to build it. And thinking about a provider we have implicit bias, again, as was stated earlier, everybody has implicit bias, but we can think about strategies for conveying allyship to our patients that help us overcome how we communicate that implicit bias. So for example, for me, language is very important. How you refer to me is very important. Did you acknowledge that I said my pronouns? What is in the environment, in the space that communicates allyship, or that you have an awareness of your implicit bias? Those are things we have to consider as providers. There's also an issue of health literacy, and so just lacking knowledge. I will say, particularly for my research about Black women, they actually do a lot of work to figure out what's going on with them prior to entering any kind of hospital environment. They think it is their role to be knowledgeable because of how they've been treated with stereotype threat and other circumstances. And so they use the internet. And they come in and they say, I've learned this about myself, and I want you to either confirm or deny it, and let's work together to figure out any solutions about my problem. And they're also often dismissed. And the provider, and this has even happened to me personally, has said, don't go on the internet trying to figure out things about yourself. And so because of the impression management strategies that Black women use, they're already diminishing trust, because it's like I'm doing this work to be in a shared decision-making state, and I'm being dismissed. So part of that health literacy is getting to know the person and not assuming that they are illiterate, in terms of understanding their disease or what they're experiencing, but when they are, being able to provide that additional information. Then there's that logistical component, for providers, thinking about the lack of time that people receive, lack of patient-provider relationship. I will say this, in terms of my clinical educators, a lot of them don't perceive themselves as researchers. They don't perceive themselves as doing scholarship. A lot of my work is promoting that in our clinical education team and saying that you too are able to do any types of research. You can engage with other folks that do clinical trials, learn a little bit about them, and be able to convey that in these clinical education spaces. Doing that, a little bit more of that work with our clinical educators can really myth bust and take out some of those things that they assume about clinical research, and allow them to be able to participate. And I think more collaboration with those clinical education folks could be helpful. And then there is the cultural aspects of things. And so thinking about family, thinking about responsibilities. A lot of patients have this expectation that it's a large time commitment to be a part of any kind of clinical trials or clinical research. Thinking about incentives. Do the incentives match the time allocations for patients? I know you have to talk to your IRB boards about how much incentive do you give, but I've really gone into thinking about travel incentives, and do they need to ride a bus, or do they need vehicle transportation, or can we feed them? Those types of elements to really knock down the barriers. So not only do patients or providers or all of us need to work together in order to encourage pursuing kind of representation in these studies, there are mandates, there are guidances that come down to help. But again, we talked about a lot of these in this conference today, and some of these are not actually no longer represented. So in March of 2025, I would encourage us to think about ways that we can pursue some of these things when the mandates that we originally functioned off of no longer exist, and are questioned by certain colleagues, and how do we get everyone on board to pursuing this work when there are social and political elements that are asking us not to. Okay, so that's a lot of background, but how about medical education? I shared a little bit about a provider's experience, but I'll start from the top about the foundations of medicine or medical education. And so we use a competency structure when we think about medical education in our learners, and we want them to reach a level of competence in the work that they do. That has been debated and negotiated a lot, and thinking about what it means to be competent in a particular thing. Seems like that there is an endpoint, which there is not. Education should kind of be lifelong, but that is the current strategy we're under. I just pulled some relevant foundational competencies for us. So thinking about patient care and procedural skills, it should be evidence-informed and equitable. I'm pulling things that I think are really relevant to this clinical research topic, and that is in undergraduate medical education. In GMB, it's the same, and you need to have effective treatment options. In terms of medical knowledge, you're supposed to be able to integrate foundational knowledge into the work that you do. And for GME, it's supposed to be evolving biomedical knowledge or clinical epidemiological knowledge. Something that we use in our clerkship experiences is what we call RHYME, which is recorder, interpreter, manager, and educator. This is the RHYME framework that we use for our students. Our students are supposed to be master recorders by the time they leave our third year clerkship, which means the history and physical exam should be very, very thorough. They should know everything about the patient population. A lot of our students balk at that because they are like, well, my preceptor just writes these really quick notes. Why can't I just do that? That seems to be acceptable in EHR. And that is like, no, at this level, we need to know that you understand how to do this correctly. So our medical students are spending a lot of time with patients in order to learn about them and produce the best H&P that they possibly can. We could leverage that environment to educate them about particular clinical trials so that they are encouraged to maybe recommend patients for studies because they know their patients more, and they pride themselves in knowing their patients more. Practice-based learning, they have to provide evidence, be reflective, they have to investigate and evaluate care and appraise and assimilate scientific evidence. I'll talk a little bit about this more, but I think these are really guidelines for us through these kind of competencies to really encourage this type of work in an education framework. And then interpersonal communication skills. Again, can you effectively communicate with your hospital team, with your patients? How is that demonstrated? What do patients say about you? And then thinking about your communication skills and how you exchange information. Another thing that's on here is like a systems-based competency. The more I listen to folks speak today, I think that that was one that was relevant, but that is the disadvantage of making this slide in early February. And so I'm thinking about how not all clinical research is thought of, or researchers, period, are thought of as a part of that systems-based process. They usually think about nurses and social workers and different folks in the hospital setting, but they're not thinking about researchers. And so how do we engage researchers in that space? So here are a few things that I list in terms of overcoming those barriers. From a learner or trainee perspective, again, if they were aware, they could probably help promote participation in these studies. And so I think about weekly conferences in our department. They have to actually attend conference at all 4 hospitals. We have Eskenazi, the VA, Methodist, and University. So they're doing those in a weekly time frame. Could we talk about clinical trials, eligibility, and different things in those spaces so when they interact with patients, they can share that information. Morning reports are something that our residents do. That is another space where we can include learners and trainees in this process and help engage in clinical trials. Implicit bias, we can offer the didactics to do that if they allow us to do any more in the future. Some of the language says that we can't talk about anybody's bias any longer, but I think that there are other ways to really consider. And so when we talk about guidances or mandates, for example, I help lead and peer observe our impact sessions. Our educators are supposed to give sessions about their subspecialties to all of our residents. I have a rubric that outlines the things that I expect to see in their talk when I do a peer observation. Health equity is something. Is there a diversity in terms of the types of literature you're citing? Are you representing different populations in your slides? And so creating guidances like that are kind of embedded into the work can be an opportunity to engage in mitigating bias, implicit bias particularly. And then logistically, if learners and trainees can learn more about the logistics and these different details, I think that they can help support patients. And someone brought up earlier about these patient navigators and being able to share that kind of information. I think about a student as a patient navigator, and most often they're able to help while they're navigating the system. It's a kind of low-hanging fruit. You're not as intimidated by a student. You're really encouraged. A lot of our patients are encouraged by the students they see and want to engage with them more. And so these are the folks that can really encourage patients to participate. In addition, I thought about curricular enhancements. We are really focused on evidence-based medicine. So a lot of the requirements for students is to do an EBM project. And so this is the conscientious, explicit, and judicious use of current evidence, best evidence, in making decisions about the care for your patients. For me, I see clinical research as EBM. And so engaging in that work and learning from the ground up how it works, how a study is designed, developed, what are the inclusion and exclusion criteria for patients, and eligibility criteria. All of those things can really help pursue this requirement that we have for learners. And so thinking, because right now we mostly just have them kind of look at articles and evidence and evaluate it using a PICO framework. And so how can we move beyond just kind of that reporting level into really engaging? And then that kind of moves us into like prioritizing experiential learning. A lot of our experiential learning opportunities are in the community. So they'll either do a student outreach clinic, or they're going in the community like we have some studies where we go to barbershops and we go to different places and engage community members. Students are really excited to do that work, so are residents. And so how can we integrate what we need from clinical research experience into what already exists? So what is the impetus for this type of work and building such an infrastructure? I think we can allude to that there is a strong reason to overcome these barriers. But ultimately, the mission of academic medicine is to prepare these future physicians to meet societal needs and future needs. And as we know, the minoritized population will be the majority by 2045. And so if we do not begin to fill this gap, we're going to see large problems in addition to the many that have been stated earlier today in this conference. In alignment with policy and advocacy initiatives, medical research is supposed to be this innovation that transforms lives. This is a part of our mission, and we heavily rely on clinical research in order to do that. We also have to leverage the teaching hospitals in that capacity for being conduits of research implementation, and having this quality, safe, and valuable healthcare that's equitable. And so it is imperative that we think about how we integrate all of the things that we do across so that we can provide that and meet that mission. And then having partnerships with the community can anchor trust. And I think trust building is an activity that is important not only for schools of medicine, for healthcare organizations, but ultimately for researchers as well. And so then we think about regulation and accreditation. And this is always the driver. I think from an anti-racism standpoint, we talk a lot about how we're not trying to change your mind about something. It's not my interest to change what you think about a particular issue. It is, if it's important and it's the type of work that we need to do, we all need to do it. And so in order to get out of the business of changing minds, we have to embed it in policies and practices. We have to have regulations, and we have to have accreditation standards that kind of force the issue and say, in order to meet the need, this is what you need to do. We can also incentivize those best practices, as was kind of a question posed earlier, but I really like the approach of being intentional from the onset. I think about the work that you all are doing. I try to create an analogy in my mind for it. It's about how I develop curriculum. I develop my curriculum with intentionality on the onset. I think about the learning objectives that I want to meet, and I incorporate those in them. I think that you would do the same with a clinical trial. And so what are those objectives? Is filling the gap in terms of health disparities an objective? If it's not, it should be. And it's the same thing that I use in my approach for, or I encourage when I'm educating the learners. I want to educate all learners, and I want to be equitable in that. And then these can promote industry best standards. So when we think about moving towards health equity, what is needed? I put consistency in government. I beg for some consistencies in terms of the regulations and the guidances that are offered, and having anti-discrimination trainings for our learners. Investments in clinical trial sites for underserved communities, thinking about the places that people are and going to those places. Sustained collection of demographic data, because I heard a lot today, we talk about race and ethnicity, and we talk about socioeconomic status and things like that. I would like us to move in a direction too of being intersectional. I'm not hearing a lot about like If it was a Latina, what does that mean for her health outcomes? If it is a Black man in rural communities, what does it mean for his health outcomes? Without the collection of these demographics, we can't make those intersectional connections, and we can't make any proper inferences for particular people. I think this was talked about, high impact journals, drive scores, and then incentives. And also just moving learners and trainees toward academic careers or thinking about research. One thing we're lacking in medical education is exposure to research for our medical students. It's very limited opportunities. This is because we have a busy workforce. We have clinicians who are trying to conduct their research for their maybe tenure, promotion reasons, and don't think about wanting to be slowed down potentially, and they don't know if a learner has the skills to pursue certain research. Also, we just don't have the infrastructure that's built to say this is a requirement of you, and so we really need to think about that. One thing we're doing in our residency program to kind of move the needle is saying at baseline we have an expectation that by the time you leave this program, you can conduct this level of research. You've interacted with colleagues. I'm sorry. Is that, I'm done, or is that, okay. Sorry. So just quickly, these are my conclusions. These are the responses to the questions that I had, and I thank you so much for your time.